One more. Test, test. 1, 2, test, test. Test, test. Mic 4, 2. Test, test. Mic 4, 3. Test one more. Test, test. Mic 2, 2.
You all ready, Dr. Duncan? All right, I'm going to go ahead and call the Quality and Patient Safety Committee meeting to order. Thank y'all, everybody, for attending. We may lose our quorum at 2:30, and so I'm going to just kind of skip around the agenda just a little bit. So just follow along. I'll announce where we're heading, okay? I don't believe there's any citizens wishing to address the committee. No. Okay, so we'll keep going. I would like to make a motion to, can I make a motion? I would like to entertain a motion to approve the minutes from the August 12th quality meeting.
Move approval.
Have a second.
Second.
So we will approve the minutes from August. And then we will start with, as we do all of our quality meetings, with Dr. Carla Putty in a patient voice. Thank you.
Thank you, Dr. Holland. I think there's just a video for us to share today. Is it ready to play? I've been given.
I would still come to JPS just because of everything that I've experienced here. Because it doesn't have to be bad. It doesn't have to be a death sentence. It doesn't have to be, oh my gosh, things are just going to fall out from underneath me. It doesn't have to be like that. I got diagnosed with stage 4 prostate cancer. I had no idea what was coming. I had no idea what the process was going to be. I didn't know how this was going to come together. I didn't know what kind of surgery or how many surgeries or anything initially. It was hard to swallow, and at the same time, I knew my life was about to change. And that was scary. But I also knew this is where I get to walk in my faith. And this is where I know that the people that are caring for me at JPS are doing the absolute best they can. Oncology, the radiation, is that where we want to go? They're my buds down there. These guys are great. It's been a while since I've seen them. Hey. How we doing? Hi. When I walk in and somebody walks up to me with a smile that actually cares about, well, what's going on? How you doing? What's your name? My name is so-and-so. That speaks volumes.
My true accomplishment at the end of the day is just to make it just a little easier. If I can get them to smile, if I can get them to laugh, just kind of settle in. Like, again, nobody wants to be here, nobody wants to do this, but if I can make it just a little bit easier for just anybody.
A lot of times, just talking to them every day, even though they're not writing it on paper and saying you're already doing a great job, we can just tell by their reactions to the way they're being treated.
Understand that people are working to help you, regardless of the situation, Whether you have to wait, whether you have to go to 5 appointments a week, whether you have to do this, that, or the other, it's all about you. And JPS is all about you. Give me a hug.
How
Give
are
me
you,
no
Eric?
fist bump.
How are you?
I'm blessed.
Good.
I love your hair.
Thanks.
What'd you do?
I'm learning how to curl it.
Oh, it looks great. I learned so much about me and about where I fit in and what can I do for you. And I've always had something to offer, but now I have something special, and that's experience, strength, and hope when it comes to this kind of situation for others, because I got it from other people in my church and my family, and I keep going back to that, but that is what kept me going, and I hope, that I am blessed with the opportunity to share that with somebody else.
Ring this bell 3 times well. It's told to clearly say, my treatment's done, this course is run, and I am on my way.
Yeah! Woo! you.
Yeah, but
That's good.
every 4 months or so, we get to share one story with you. And I think Eric says this very well. He says, JPS is all about you. I think we bring a level of humanity to healthcare that is rarely seen in healthcare. So I'm glad we were able to share the story with you. Thank you.
All right, so we're going to jump ahead just a little bit. Dr. Carla Pudi and Dr. Badamosi are going to talk to us about our fiscal year 2025 QAPI plan, and that way we can get to the items that are requiring our action.
Sorry for causing seizures, but don't look at these slides. We want to move along. Dr. Badamosi. We have brought the QAPI plan to you every year to make it better, and this year is no different. We want to give you a quick update on the QAPI plan, and then Dr. Badamosi is going to share with you some of the new changes we would like to recommend to the plan.
Good afternoon. Thank you, Dr. Kalapurdi. So we have brought this QAPI plan again before you, following your approval of last year's QAPI plan. We are bringing it back for some updates, as Dr. Kalapurdi mentioned, and for your approval as well. We intend to be doing this every year, bringing it back to the board for additional input and improvements. Since your initial approval of our QAPI plan, we've had the Joint Commission come by, and one of the focus of their visit is to evaluate our quality assessment and performance improvement plan. And this was a major focus of their review. They recognized it as one of the best plans they've reviewed in all of their surveys, and they actually took a lot of lessons and insights from our plan to share with other organizations. They especially commended our plan for a strong bidirectional flow of information from the board to the bedside, as well as from the bedside to the board. And they praised our leadership and the board engagement as evidenced in the minute meetings that they actually reviewed. So by and large, it was really a great review that we got from the Joint Commission regarding our QAPI plan on how well laid out and functional it is and how we have executed it so far. For FY25, we are bringing back to you some proposed strategic priorities. All of the bolded sentences there are new, and all of the ones that are not bolded are actually old that has been approved, and we intend to continue with those. Top amongst our new proposal is patient experience. We really want to highlight patient experience and really improve on that, because we believe it's very important to not only provide clinical excellence, but also ensure in the realm of patient experience, we also provide excellence there. Additionally, all external benchmarking agencies, including CMS, are also prioritizing patient experience. So we feel we should also do the same because it's important and it ties strategically to our true north. Also, we want to enhance maternal health by keeping a very close eye on our maternal morbidity and mortality measures, and also our NTSV cesarean section rate. We want to reduce that to meet with national benchmark. The third strategic priority we are proposing for approval in this document is the Africa program. We aim to achieve a threshold performance in this program. Africa program, as we have discussed in prior meeting of the board, is a bundle of 6 metrics, 3 of which are improvement over self metrics, and the other 3 are benchmarked by the state. And it is primarily focused on the Medicaid population. But we do believe that lesson learned from this Africa program, with the way we are implementing it, we are applying it broad-based to all patients and all comers that come to JPS. And we will also be adding any other measure or performance metric as approved in our FY25 AIP goals once approved. The other major amendment that we are making to our QAPI plan is the Performance Improvement Governance Council. We did set up this group to actually serve as a formal framework to ensure that any project, any performance improvement projects that we will be implementing has strategic alignment with the organizational goal. We want to make sure we have a group of leaders that oversee this process in addition to quality, to ensure that if we take on a project and we want to execute that project, there is no duplication in the system, and we're following best practices and evidence-based methodology. Whatever lesson we learned also will be hardwired into our processes and procedures. Also, we are committing ourselves to zero harm focus, and this is also part of the requirement by CMS that organizations should actually commit themselves to zero harm focus. And this really means we will be focusing on all of those harm events and bundle with a goal to reducing those to zero. We will continue in a continuous improvement process, really hardwire all of this improvement to ensure that any harm event is investigated, the reason why it happened is established, and we put in measures to actually avoid it and hardwire those improvement measures into how we do things.
So,
Yes, ma'am.
would you just, going back to the last slide, for Dustin, who really does not have the clinical, that some of the other team members, can you speak to what CAUTI, CLABSI, SSI are?
Yes,
Those
ma'am.
acronyms are?
Yes,
We will
ma'am.
be following.
Yes, ma'am. So CAUTI is catheter-associated urinary tract infection, and CLABSI is central line associated bloodstream infection. And PSI is patient safety indicators. PSI 90 consists of 10 patient safety indicators for patients that have undergone surgery. Did they get infection after surgery? Did they bleed after surgery? Did they have a need to be intubated after surgery? All of these events are regarded as being potentially preventable, and that every organization has to commit itself to evaluating, analyzing, and preventing all of these events from happening. And SSI is surgical site infection. After surgery, do we have any infection of those? Because those, again, are regarded as being preventable, and we have to do everything we can to avoid those. And we have to commit ourselves to track, improve, and hardwire improvement in all of those areas. Thank you.
Thank you.
Yes, sir. This is our QAPI plan again. It's essentially unchanged. We have included other hospital departments, hospitalist anesthesia, which we have been evaluating, but we feel we should also add those formally to the QAPI plan. Otherwise, it's essentially unchanged. There is a small asterisk at the bottom that committees, program, and departments will be amended as needed. If anything comes up later down the year, based on board discussion or senior executive leadership discussion, or just any important event, we'll add it to our corporate plan as needed. Before I move to other policies, I don't know if there are any questions or comments regarding our corporate plan.
Comment, especially Dorothy has watched this evolve, and Dr. Holland more recently, but I do want to thank the team for really taking quality up to a network and a system level and not having it decentralized across. We do understand there's work that goes on in each of these specialized area, but I think really to be able to take it up to a network and drive the work from that level is in the best interest of the organization and the patients that we serve. So thank you. It's taken us a number of years, but I think we finally got it.
Thank you.
Here now. Do we need to approve this?
Yes,
ma'am.
we need to approve this as well as
Okay.
2 other policies.
Oh, okay.
I don't know if we'll do those one after the other or if I should present the other 2.
Are you finished with
Okay.
No, I think we're done with the QAPI plan presentation. Yeah, we're
Yes.
done with the QAPI plan.
On the Performance Improvement Governance Council oversight, is this already in existence, or is this something that is going to be created?
This is something that conceptually we have put together, and it consists of the Chief Quality Officer as the chair, but we do have the Chief Nursing Officer as a member, the VP of Operation as a member, and other frontline staff and other senior executive leadership as a member. And really the importance of this is to create that awareness within quality that People shouldn't be doing performance improvement projects based on, oh, I've seen this work somewhere before, or I just have a really good idea that this is going to work. Let's start doing this, or let's put effort into this as an organization. We felt that we needed to increase the bar to ensure that any performance improvement projects we're undertaking is evidence-based, has strategic alignment to the overall organizational goal. There is awareness across the organization that this is going on. There is no duplication, and any conclusion that we make is really hardwired. The key thing is the sustainment. We really don't want to start a lot of projects and not finish them, or just come to conclusion without those being hardwired into our processes and procedures.
So is the idea behind this that before anything gets started, any of these performance improvement projects get started, they go in front of the council
Yes.
and get approval?
Yes, ma'am.
It adds a sense of rigor and structure to the process improvement work that we haven't had before. We have had individual oversight of projects, but this provides a much higher level of rigor to the process.
I think it's just also a good idea just to see the breadth of what's being done out there. 'Cause
Absolutely.
Like to Dr. Duncan's point, it seemed very decentralized up to this point. So I think this is wonderful.
I also think if this works the way, if you are looking at a process, every department that has some action in it is a part of making sure that their piece fit into.
Correct.
Okay.
That is correct.
That
Yes,
is
ma'am.
great.
Correct.
And that
Yes.
will, because a lot of times you start something and the key department has been left out. And so you
Correct.
implement there saying, we don't know nothing about it. So, yeah, I'm very glad to see that back.
And there's no need to duplicate what's already been
Right,
done.
right,
Well,
right.
sorry, yeah.
They used to have what they call a pit crew. Remember that?
PIT crew,
Is that
performance
pit
improvement.
crew?
Yeah, PIT crew.
That was similar to this. It was,
Yep.
Doesn't roll off the tongue as well as. All right, so I will entertain a motion to approve the QA 1000 Quality Assessment Performance Improvement Plan for fiscal year '25.
Yes, Dr. Holland, I make a motion to approve.
second.
Motion is second, so we will approve the fiscal year '25 QAPI plan.
Thank you very much.
Okay.
The two other policies are really just an update. There are no significant changes in them. The MM600 policy and the accompanying procedure 601 really deals with medication diversion, and the only change is just a language clarification using credentialed practitioner in exchange for licensed independent practitioner and advanced practice provider. Otherwise, the substance of the policy remains unchanged. For NPSG 900 policy and the accompanying procedure 901 is a Sentinel event policy. It really aligns our policy with that of TJC. TJC no longer requires that all Sentinel events be reported to them. They have left it at the discretion of the organization. We have moved towards that policy as well, that we will leave it at our discretion. Additionally, we follow the TJC definition of Sentinel event, but TJC has constantly updated the number of events they consider to be Sentinel, and they have now partnered with the National Quality Forum. And the two bodies are now merging together to define what Sentinel events are. Rather than needing to be coming before this committee every time there is an update to which is Sentinel event, we just say we will investigate any Sentinel event per our policy, and our reporting will be at the discretion of the organization.
Any questions about that?
I have one question. I think I saw that you would be having a consultant, a patient safety and clinical risk consultant added. That's new. Is that?
It's a title change.
Okay.
It used to be clinical risk,
Okay.
It's
I got it.
CRA. Now it's PSC, Patient Safety Consultant. Yes,
Yeah,
it's a
okay.
title change.
All right, okay.
Yes.
That was my only question. Okay.
Yes, ma'am.
Is that just to reflect the wording of the TJC? Is that what they were Is that a required position by them?
No, it's just so our PSC, our patient safety consultants, are the one that do the investigation of all of the Sentinel events or even patient safety events as reported through our event reporting system.
Are there any further questions? Okay, then I will entertain a motion to approve the MM 600 and MPSG 900 and 901 amendments.
Move approval of MM 600, NPSG 900, and NPSG 901.
I'll second.
Thank you. All right, so now since we have done all of our business, we'll go back in our agenda and we will talk about, I'm really excited to hear the results of the Joint Commission survey report. And I know on Thursday we'll hear even more at the full board meeting.
Thank you very much. I have here with me Jill Farrell, our COO, and Angela Norris, the Executive Director of Quality. Jill was the leader for our TJC survey preparedness, and I'm just going to turn it over to her to get us started. Jill?
Thank you, Dr. Batamosi. We did have Joint Commission come not too long ago and had a very successful survey. Dr. Batamosi is going to provide a little bit more detail, but just to give you kind of the breadth and the depth of the Joint Commission when they came, they brought 9 people to visit us, and they were here for 5 days. They went to every single clinical area in this organization. They went to every single community clinic as well, which is highly unusual. And so we are very excited to say we had a very successful Joint Commission survey. Again, couldn't do it without the people next to me, in addition to many, many others, including our EVS team, facilities team, our overall quality team as well. We also had a weekly steering group that met that included people from facilities and EVS as well as from nursing. And so only possible because it's our entire team. We will recognize our entire team on Wednesday, the 13th, to celebrate kind of a successful survey. But in addition to that, in a very tough time, we're looking at Joint Commission and CMS. We're kind of on that swing right now where CMS is making visits alongside TJC. They've seen an increase in condition level findings where people are actually coming back to organizations to resurvey areas they find issues. And used to be about 25% of hospitals and systems would have a return visit. This year, they're trending towards 55 to 60%, and we know many partners that we work with and our peers are experiencing that as well. So overall, we did a phenomenal job. Comparison to 2021, about a 25% reduction in overall findings. When you look at our SAFER matrix, which is how they actually score us related to the findings, we can be anywhere from low to high and then as limited to widespread. We had most of our findings in that low and limited category. 2021, it was really kind of spread more across the SAFER matrix. And so overall, less findings, lower risk findings. And so we are very proud of the work that we do, not just for when Joint Commission comes, but really it speaks to the work that happens across the organization every single day to keep our patients safe. And so Dr. Batamosi, you want to talk a little bit more about the actual survey and program and kind of what they were impressed with our teams?
Yes, thank you, Jill. So as Jill mentioned, it was a 5-day survey. We had a total of 9 surveyors, and including a field director that was supervising the surveyors. And the hospital program, we had a nurse, physician, administrator, an ambulatory specialist, a generalist, and an engineer. As Jill mentioned, they really did go everywhere. They went through every single crawl space we have in the hospital. They report, yes. Yeah. The surveyor stated they covered 2 million square foot of space was evaluated during their survey. They went through every single clinic that we had, interviewed staff members. What struck them the most, and they kept saying this over and over, was staff engagement, the team members. Unlike most other organization they go to, every clinic, every unit they go to, the staff actually go to them. Let me show you what we do. This is what we do. The other thing that struck them per their report is the consistency across all of our clinic. And the recognition of all of the staff members, especially the quality staff and the infection prevention staff. Each clinic they go to, they knew them by name. It's not that, oh, long time no see. No, oh, yeah, I got your email sent to me yesterday. What you told us last week, we have fixed. They kept really repeating that over and over again. And I think, as Jill mentioned, it deserves special mention, our EVS team. They did a terrific job. They were so impressed with our EVS team that the lead surveyor requested to go personally thank our EVS team. They did a fantastic, she requested we get them all together, and she actually went down and gave them thanks because really they did an amazing job. And under the leadership of Jill, many times we had a lot of meeting. We had a lot of nurses, physicians, executives. They were here without us knowing the Sunday before to actually go around again to look at our hospital. What are we missing? What needs to be improved? Everybody came here Sunday in the morning, went around, looked around, provided a report, and it really speaks to the team spirit that everybody was engaged throughout this survey. A lot of the issues that were identified during the survey were fixed on the spot, minor issue. And this led to this feedback from the surveyor that we did not have any conditional level findings compared to about 55 to 60% of other organizations. All of the findings that we have were standard level findings, and they were one-offs, and they were very specific. I will give an example. A forceps was found that had a tape on it. We have over hundreds of thousands of equipment, including vendor equipment, that they went through. They only found one in an outlying clinic, and they didn't find any other one. They had to cite that at a high level. And they themselves really were not happy they had to do that, but that's just what they were doing. So it was really one-offs when we got cited. And even more impressively, and they kept saying this over and over, the lead surveyor that actually surveyed our behavioral health was like, I find myself saying, wow, everywhere I go to. Given the complexity of the patient that we see in our behavioral health units and how complicated that operation is, being the largest provider of behavioral health services in the county, they were very, very impressed. And our behavioral health had 0 clinical findings. And in the world of survey, that is not heard of. That is not something. They looked through everything. They did not find anything to cite. And they really commended, as mentioned by Jill and earlier, great culture and staff engagement, and we received a lot of commendation from them. Our high-level disinfection, they did meet a staff member that has been here for 7 days that was dealing with one of our high-level dysfunction, and she was able to tell them our process. Really, everything is hardwired in our process. They commended us for etching our sterile instrument, our biohazard transportation from community health, our pre-procedure huddle, some of which they insisted on witnessing, and they saw how we do things. They loved our QAPI plan. They felt it's one of the best ones they have seen. And our MVP project, that's multi-visit project that we have brought here, the feedback they have for us is, why haven't you guys published this? This is a best practice. And our health equity under the leadership of Dr. Elliott was also shared with them. They were impressed with what the collaboration between the hospital and the community. What goes on with the community? We are not isolated, identifying at-risk patient that needs help with other structural and SDOH, how we go out of to really ensure they get the care they need outside of the hospital was also commended, as well as our EOC documentation, environment of care documentation management. So really, it was a very good visit. They were thorough. They commended the organization. They commended leadership. because they read all of the minutes, they read all of the inputs that the board had in the cooperative plan and the leadership and the review of our quality that we present here. And it was really, they were very, really, at the closing ceremony, it's really unusual what happened. They appreciated the organization. It was more of a celebration than a closing ceremony. So good job all around to our team members, and a lot of people rallied around, and our team spirit showed.
And thank the board, because there were no leadership findings, which
Yes.
really says that as they looked at how information moves up and down in the organization and the board's ability to receive this, but also to respond to it, was really outstanding. So I do want to thank the board for your involvement, appropriate involvement.
That's just amazing. I am so very proud of all of y'all's hard work and just the hard work on behalf of the entire staff and the whole entire JPS team. Just these findings just blow me away, and I'm sure I'm reiterating the thoughts of all the board members as well. So thank y'all.
Thank you. I also have to thank Angela, my amazing partner. She's my executive director. All of this, she worked tirelessly, talking and texting each other through the night, off hours. She's just amazing, experienced all-rounder. And I know she doesn't like talking, but she's just wonderful. Couldn't have done this without her.
Yeah, Angela and her team did a phenomenal job actually orchestrating the entire week for us. It was completely seamless, and so her team was everywhere. Our surveyors actually walked into our room, which we didn't really have a name for it, but they named it. They called it the Incident Command Center, and they would come in there and visit, and they were very impressed with the operations and the ECR that we had, and that was led by, obviously, Dr. Batamosi, as well as Angela and the team that reports up to her, and so definitely mechanically and really the organization of the survey day and week itself was really attributed to Angela and her team, so great job.
Awesome.
So Brian, I'm going to ask you, since you're sitting here, you've been here now for how many years with the organization? 22. And any comments that you have, having watched our organization go through every 3 years, these joint commission?
Yeah, this was pretty flawless, and it was great. I think the preparation that we had was incredible compared to what we've had before in the past. I really appreciate that, and everybody just being on the same page. Yeah, you can feel it when you're in the clinics. It's funny, I was I think at 3 places that they were each day, and I thought, oh, they're just following me around. But the team was engaged and ready to go, and it was fun to watch that.
Thank you.
So next we'll move to the 2024 Culture of Safety Survey results. Dr. Batamosi.
Thank you. So the Culture of Safety Survey, it's really regulatory, and it provides us with an insight regarding organizational strengths and areas for improvement. And the Culture of Safety Survey, this annual survey, is in addition to the daily safety calls that we have that provide senior organization leadership with awareness with what's going on at the front line. This Culture of Safety Survey is administered as part of the engagement survey, and it was no different for 2024. I'm very happy and proud to announce 95% employee participation, and it was conducted by Gallup using the AHRQ methodology. There are 9 questions in total for the Culture of Safety Survey. The first 2 questions deals with critical information flow. How does information flow during handoff in the same unit? And how does information flow between units during transfer? The next 2 questions deals with culture management. What is the thinking of the frontline staff regarding leadership involvement in culture of safety? And the 5th, 6th, and 7th question deals with error information communication and remediation. When error happens, how is it communicated back to the team? Do we act on errors, and do we provide remediation? And the last 2 questions deals with teamwork index. When error happens, how do the teams respond? Do they respond as a team or as an individual? I will go back a little bit to talk about the 2023 Culture of Safety Survey before I go to 2024, because I want the board to be aware that after presenting the Culture of Safety survey to the board last year, we did identify to you that our key focus area where we didn't perform as well as we think we should was to strengthen the flow of critical information. After this presentation to you, we took that result and cascaded it down, and we solicited feedback from leaders and frontline staff. We presented it at the MEC, the Nursing Council, the Nursing Manager Council, even to the residents, the house staff. We presented it and got some feedback. Off of those feedback, we did initiate some important action plans because we really wanted to target it. And we emphasized during this tour of the organization with this result that it's important we use standardized tool to hands off and to use well-established protocols during hands off. And we also felt, though, that we need to get specific insights from the organization regarding what is happening, if there's anything. So we conducted a short follow-up survey to target looking at hands off from night shift to day shift, hands off from day shift to night shift, hands off from the OR to the ward, hands off from the procedural area to the ward, hands off from the outpatient to inpatient. So to gain a better understanding of what's going on and how to hardwire improvements into the process. So we did learn a lot. We did have an interim analysis of the result of those, and they provided us with actionable insight regarding what the staff would like to see, the specific type of information they feel was missing. And we're now working with the frontline staff to actually hardwire this into the electronic medical record. But based on some of the preliminary improvement that we did following 2023, I'm happy to share our 2024 Culture of Safety Survey. If you see to the far right, in every single measure, we went up significantly. Gallup defines significant improvement as 0.1. If we are 0.1 improvement in absolute terms from these numbers, they regard it as a significant improvement. The first two questions, as I mentioned earlier, are the critical information transfer. You can see we have gone up significantly, and in terms of percentile score, we're now beginning to approach the 80th percentile when compared to other organizations. For every single other metric between 3 and 9, we are above the 90th percentile compared to other organizations that Gallup surveys that are hospitals or healthcare institutions. So we do plan some follow-up, and we do intend that critical flow of information will remain our focus, because we feel we still need to hardwire some of the lessons that we learned, and we still believe we can improve this number even more than we have already, and to really hardwire our hands-off and transfer process in the EMR, and not only that, to audit our process to see how effectively it is working, if it's meeting the expectation that we think it should meet, and to really learn again from our frontline staff if it's actually improving the process as much as it will. I will take any questions.
It seems like the one that we're lowest on as far as the scoring, not necessarily the delta, but just in general, was just shift changes. And you said that that is the hardware Epic process?
Yes, so the process we have actually started looking at is hands-off in the ICU is different from hands-off in the L&D. Each unit really needs a specific type of tool, and we are not reinventing this tool. They are evidence-based tool that's already in Epic, but we need to really modify it to suit our own institutional system. And we need buy-in. We didn't want to design this system in quality. We want the frontline staff input in regards to how to design it. What information do they want? And to make the tool hardwired in our EMR and auditable as well, so that we can see that, okay, it's actually demonstrating the impact that we want it to have.
This was not, I asked the question with the compliment earlier. This does not replace the verbal handoff, but this just supplements it so that if a caregiver wants to go back in and look at what that handoff was, it gives a more complete picture.
Correct. Absolutely.
Thank you. We have one more presentation, the quality presentation by Dr. Badamosi.
This is the quality presentation from the JPS Network Quality Council. This is a high-level summary of presentations to the committee in July, August, and September. We have a total of 9 committees and programs that have presented to the Network Quality Council during this time. The first is oncology and infusion. Last week, the American College of Surgeons Committee on Cancer Accreditation was actually here to survey our oncology program, and they not only accredit our OIC, they recognized it for meeting the rigorous standards in cancer care and quality assurance. So they got another full accreditation. They especially highlighted their alignment with American College of Surgeons standard. The metrics that the OIC collects, they feel was well aligned, and they understand that in JPS, our patients sometimes present very late along the continuum of their care. And the thing that actually struck me the most during the presentation is, despite this late presentation, based on ACS data that they shared with us, the outcome of our patient is better or the same as with national trend with the OIC. So, which means wherever our patients are in their journey with cancer, whenever they present, they still get the best care that is comparable to anywhere in the country.
I think they were presenting later and younger, weren't
Yes,
they? But those are the two things that struck me, is that they were presenting later and that they were younger. We showed a little bit, compared to national average, a little bit of delay in getting them into treatment, but our outcomes were better. Were the same, if not better than the national was for those patients. So great job by the cancer care team.
Yeah, they do a fantastic job. And the surveyor also highlighted and noticed that there were no out-migration, which means when a patient starts their cancer journey with JPS, they stick with JPS throughout their treatment, which really is the most important measure of satisfaction with their care. Our Oncology and Infusion Center collects a lot of data, but I'm going to share with you some of the high-level data that they are collecting, and it has to do with colon cancer. Just based on the increasing frequency, we're beginning to see colon cancer, and our data also shows in younger people. One of the metrics that is being monitored by the OIC is timing of initiation of chemotherapy within 128 days of surgery. The targets in bracket are the ACS national average, the benchmarks that they are compared to. You can see for stage 3 colon cancer and colon cancer resection surgery and sampling of lymph nodes, we're actually doing above the national averages and the national benchmark. Some of the processes that has been worked on in a multidisciplinary fashion is actually early screening. And this goes beyond oncology and infusion center. It starts at the primary care. It starts with community outreach, then it goes to our endoscopy system, then it goes to the pathologist, then it gets to the surgeon, then it gets to the OIC. Across this continuum, there's been specific process improvement that's been put in place. One of those is Lumens, which is the new electronic system that we use to schedule endoscopy appointments, as well as document our findings during endoscopy to ensure it is structured and standardized and there are no ambiguities. And there's also a cancer navigator to assist the patient. And we do have a multidisciplinary tumor board that also review all of these cases and offers opinion regarding therapy and care for those patients. The other metric that I follow is gastric adenocarcinoma. Unfortunately, this is one of those cancers that present very late. Only 4 cases year to date, and all unfortunately presented very late. So there was no issue of needing a curative resection since it has spread, unfortunately. The other is non-small cell lung cancer. Non-small cell lung cancer causes more death than colon cancer, breast cancer, pancreatic cancer, and bladder cancer all combined, even though the incidence is less than that of colon cancer. So it carries a very high mortality. The performance of 66.67, that is below the 73% benchmark, is actually explained by we used to be about 100% on this achievement, but now the therapy for non-small cell lung cancer has moved away from the traditional chemotherapy. It has moved to targeted molecular gene therapies. So this requires, in addition to pathology, sending these samples for molecular studies and getting the specific gene and targeting that. This has caused some delay, but the outcome is actually better until all of this, because we feel the best way we can target this cancer, despite late presentation, is to go down and drill down to the specific gene that is driving the cancer. Rather than rush to the traditional chemotherapy agent, it's better to target it and give the specific medication to that cancer that has shown improved outcome. The other issue we have with this has to do with our patient population. Most of our JPS patients do not have access to this medication. So we have to go through the patient approval system through these companies to make those medication available. We do have a system, but some of those timing are actually beyond our control as an organization. It has to do with this pharmaceutical company providing it on the basis of patient assistance program. But we are continue to work on this to ensure that we speed up as much as we can so that we can offer our I will especially note as a pulmonologist that our achievement in this is really, really good in terms of ultimate outcome. If you look at the graph shared by the American College of Surgeons Committee on Cancer, we're actually doing very well. Even on the improvement they are planning to make on their metric that if you're resecting the lung, you should get more lung lymph node during the surgery to make sure you know the extent. We are actually doing that before they even go in. We are sampling those nodes with the advanced technology that JPS has been deploying. Next is laboratory. The lab also presented, and these are some of their high-level metrics that they shared during the quality committee meeting, quality council meeting. Blood culture contamination rate, we're currently at 2%. 3% is the national benchmark, but CDC has been pushing to get it to less than 1%. We are continuing staff education as well as providing phlebotomy classes, that is those that draw the blood, and we are moving in the right direction. An area of challenge is urine contamination. The target is 15%. This is one of those that's really dependent on the patient because we set up the process. They have to go into the bathroom without the staff. So we continue to educate our patient and provide a process in place with reminders in the bathroom on how to properly collect this sample to ensure that we reduce the contamination rate. Critical value, if our labs dictate any abnormal values, they document it and highlight it to the receiving team, and they also call, and that is, we're above national benchmarks for both of those measures. Utilization Management also shared their presentation with us. The Utilization Management Committee focuses on ensuring appropriate care and ensures that the care that is provided is medically necessary and that patient receive the right care at the right time by ensuring they get to the appropriate admission location, monitoring length of stay, as well as care transitions and discharge planning. We do have a very robust multidisciplinary throughput committee that actually helps in collaboration with Utilization Management to ensure we are performing well on this. We have shared this length of stay graph with the the board in the past, and we are bringing it back to show that we are sustaining the improvement that we set out to achieve. There is a slight bump in September, and this is as a result of very high volumes that we saw during the summer that led to a slight bump in our length of stay. This is the multi-visit patients per month. There was also a slight bump because of general volumes that's been very high, but generally we still maintain all of the improvement that we have seen. When this program began, we started at around 33%. We still remain at about half of multi-visit patient, defined as patient that has been hospitalized, that's been admitted to the hospital 3 or more times within the last 12 months. This is a program that meets every day to figure out why is this patient coming back, what went wrong at the discharge, what are the social determinants of health that is bringing them back, what can we do to really, is it housing, is it food insecurity, what do we need to do to ensure that we connect them with the care that they need on an outpatient basis, and it has been extremely successful. We submitted this program for evaluation to TJC when they came during the OQPI, and they really, really loved the program and how we have sustained this improvement. This is our 30-day all-cause readmission. Cumulatively, we closed the year at around 11.9% readmission rate, and we are continue to monitor it, and we are continue to, with length of stay and readmission, those two are closely linked to create a balance to make sure we are not improving one at the expense of the other. So they are the balanced metrics for each other. So our ops rate is currently at 36%. Our target is 35%. Observation rate speaks to the patient that are admitted to the hospital from the emergency room for observation for at least 24 hours. They don't need to be admitted. If they stabilize based on initial impressions and therapy, they get discharged home. If they are not doing better or their clinical situation evolves to the point of needing admission, they are admitted to the hospital. The goal is to keep this around 35%. We are actually, compared to a lot of other organizations, I know the team that's been working on this visited Parkland. Parkland is well over 50% in terms of the observation rate. We continue to work on this. There is a daily meeting of the throughput committee that works closely with our utilization management, and a dedicated physician advisor has been hired to actually help also work on utilization in general.
Can I ask a question on that before you move on?
Yes, ma'am.
They're in observation, they're dismissed, and they come and they return to the hospital within 24 hours. Is that against them? Is that go to obs, or how is that monitored?
So it depends on where they get readmitted to, and it depends on which metric we use to evaluate them. Okay. If we are using the standard all-cause 30 days readmission, if they get readmitted to ops is regarded as outpatient, but if they get readmitted to the hospital, now they've gotten readmitted to inpatient. That is the CMS definition.
Okay.
If we're using the Africa definition, any admission, either to ops or to inpatient, is readmission.
Okay, all right, thanks. Yeah,
yes, ma'am.
That's good.
Not good.
Yeah. That's good. Okay.
Get penalized, yeah.
Moderate sedation, the moderate sedation committee also presented, and these are the metrics that they follow. Pre-procedure H&P is CMS required and is safe practice to ensure that all medications that a patient is on is taken that potentially could become an issue with sedation. And timeout is a major safety issue. We're 100% with that. And all medication that is administered to the patient, once drawn out, is labeled 100% of the time. Where we have a little bit of challenge is informed consent, completion, interpreter services, use, and documentation of ASA. In a lot of this situation, they are the procedures that are done emergently, and they were just documentation opportunities. What we have done to capture all of this is to standardize our procedure notes to ensure that we do have a checkbox to indicate this procedure is emergent, or that will necessarily mean both by the state law and our policy that consent is not required and interpreter could be waived because it's an emergent situation. And we're also getting more iPads for interpreter service to be available. So now that the procedure note standardization is finalized, this is something that we'll be able to audit and will contribute to this data. My suspicion is we'll be close to 100%.
You have to document melancholy and moderate sedation?
So it's in preparation for possible, once you sedate, if the patient goes into deep sedation, then you have to take over the airway. So a priori to be prepared in case that happens. Trauma and acute care surgery. So this is a combined scorecard for our trauma service. And I'll also mention that JPS is the one of 5 hospitals nationally that is accredited by the American College of Surgeons Emergency General Surgery Verification Program. And this is a combined scorecard looking at patient that comes in with trauma or patient that comes in for acute surgery, emergent surgery, like acute appendicitis, acute gallbladder issues that need surgery. So this scorecard addresses both of those. Ventilator-associated pneumonia, this is when patients come in for trauma and they are intubated to go for surgery. If they're in the hospital and they develop a pneumonia, it's regarded as a complication that is potentially avoidable. What is our incidence? And the target is it should be less than 8 in 1,000. We are currently about 10 in 1,000. What are we doing about that? The team has actually come up with a very smart way to mitigate this, because sometimes it's not unusual in trauma situation for patient to be altered or comatose after trauma event, and people can aspirate. That will lead to pneumonia. And if the patient comes in with a pneumonia, it is not called ventilator-associated pneumonia. So they are going into the lungs with a small catheter to aspirate the secretions in the lung and send it early for microbiology. A, to pick it up early so they can institute appropriate therapy, and B, so it doesn't count against us that we did not do what we are supposed to do and the patient is having a pneumonia. So that is really helping, and that will be continued. The second is for patients that come in for emergency general surgery and they have high risk. How are we following those patients? A patient comes in for appendicitis, but they have uncontrolled diabetes and they have other comorbidities that they're going to need help with to minimize the risk of postoperative complication. The team prefers to see them in clinic within 5 to 7 days after discharge to address any issues that's going on. Unfortunately, a lot of our patients, once their surgery is done, I think our surgeons do a fantastic job. They don't bother following up as outpatient, even though that's the recommendation. But the trauma team still believes we should reach out to them, and they are now expanding our telehealth capabilities to ensure we perform an outreach to increase the appointment compliance from them. The third item is interventional radiology. There are some cases that present emergently that need interventional radiology, which is really minimally invasive procedure, either to block a blood vessel, to put in a drain on an emergent base. They really did set an aggressive target of getting this done in no more than 60 minutes. Year to date, they've had about 3 cases as of the time they were presenting, out of about 8 cases that they were only able to do after 60 minutes. So what they are learning from is our stroke program. Our stroke program has this AI tool that they use on the phone that once a patient comes in, everybody involved in the care potentially have access to that and they get real-time information. And the goal is to be able to get this patient to emergency IR. It has really worked well for our stroke program, and we discussed it during the Quality Council with our IT CMIO present, and they are looking at this module to ensure that there are any technical technical concern vis-a-vis integrating it into our system. Once that is done, it should help. The fourth metric is when a patient comes in with trauma, before they go to CT scan, the fastest way to figure out what's going on within the abdomen is to do a quick ultrasound at the bedside and to see if there is blood within the abdomen. If that is the case, they go straight to the OR. They don't stop at CT scan, you just saw. They are doing this and they are creating a process to actually start uploading it into the EMR. The reason why this process is important is we want to make sure that the images that have been uploaded is of good quality, and that this is bedside ultrasonography is something that's becoming ubiquitous, and ultimately the trend is it's going to replace stethoscope in some fashion, that medical students, everybody have pocket ultrasound. So it's not everybody that should be able to just do ultrasound and upload it. So there's a need to create a rule and a process. Anybody that should be able to do this should be credentialed and should be somebody that is appropriately trained. And that is what this is about. There are no national benchmarks. They are actually way ahead of the curve with this metric.
I have one question on this. Actually, I have a couple. On the ventilator-associated pneumonia, are they taking into account patients who were intubated in the field prior to coming to JPS and then re-intubated here?
Yes, all comers. They screen all of the patients that come in.
Okay. And then my other question is, on the emergent IR case, sometimes the things that the IR team does is different than, say, that the stroke team does. Is it possible for them to get a diagnosis within 60 minutes? Is that a realistic? You mentioned JP drains and things that it takes a moment to kind of figure out what's going on with these patients.
You're absolutely right, Dr. Holland, which is why I personally believe that setting 60 minutes was a fairly aggressive goal from their perspective, because to your point, we need to reach a diagnosis. We may need to do other investigative study before we get them to therapy, because interventional radiology is a therapeutic intervention. So they set this goal, and we are monitoring it. They're just trying really to see how best can we make this, can we really achieve this. Again, there are really no national benchmark. This is really, they pushing the envelope on this metric to continue along, because again, JPS as a level 1 trauma has this tradition of really being at the cutting edge, at the edge of improvement, which is why they adopted this metric.
Bedside ultrasound.
Yes, ma'am.
So that's read by the person who's actually doing it. Is that correct?
That is correct.
Is there any final read that's done by
only if there
a
is a
trained radiologist, or are we doing any auditing to say that the read was appropriate? I'm just,
yes.
As we start to get into more of this kind of bedside, which determines what the next steps are, kind of how are we ensuring that these are read correctly?
Yes, that is absolutely correct. As you know, JPS has a fellowship in bedside in ultrasonography by the emergency room, and it's part of the emergency room curriculum for them to be able, they have to be signed off and certified to do it. To your point, Dr. Duncan, it's not everybody that's carrying around ultrasound that should be able to do it. And we have a multidisciplinary team that's actually been working on standardizing this process to ensure that it's not everybody that have ultrasound A that should go ahead and start doing ultrasound on the patient. B, there are a lot of questions about the images. You cannot take away patient images for privacy reason on your own, or just use your probe. How are we sure you are disinfecting it appropriately? So all of these questions we are answering, and we have a multidisciplinary work group that is trying to streamline a proposal to go to the MEC, senior leadership, and ultimately to the board before we adopt it. But in the narrow context of trauma, this can only be uploaded by the trauma attending as well as the ED attending into this process.
Check each other. Like if the trauma surgeon and the ER physician are both doing it and they come to the same conclusion, it's like
that redundancy. Yeah, I like that.
But it does eventually.
Sounds like
That's
the
what
decision
Dr.
has already been made to use that information for the next So it may not, but I think we probably need to do some auditing to make sure that.
Absolutely.
It'll be interesting to see what other systems that have that as already hardwired, how they kind of verify that it's accurate.
Yeah.
I mean, I think it's very accurate to those who are good at it, but you have to get to that level.
Absolutely. Absolutely.
Yeah, answer that.
Sure.
Team and they have a process, they have an internal QI process. So I think they have a leader who actually has been trained in that. He's trained in point of care ultrasound. And they have a process wherein you're doing the same quality checks of those images. They go into a different side of the PAC system, not the radiology side. So they have an internal QI process. So if you do a fast exam or you're doing a bedside, a paracentesis check, or you're looking for fluid in the thorax, when they do those, they go into a different set, and then there is a quality check that happens on the ED side. I can tell you that for sure. I think on the trauma side falls into the same thing because the trauma is a multidisciplinary review. So when they have those cases, they also have the same QI check. I think what Dr. Badamusi is trying to do is create that process for the entire institution, because we have family medicine residents who can do an ultrasounds on the floor. So because technology has become ubiquitous, they can carry probes everywhere. So what we are trying to do is, what he was trying to describe is an institution-wide process to make sure when a bedside ultrasound is done, those images are captured, they are read by somebody competent to do it, and then there's a quality check for that. But when it happens in the context of trauma in the ER, there is a very good QI process to make sure that the image is actually, there's almost a read to see, did I get it right? And yes, there's a process for that. Just want to make sure you know that happens in the ED and trauma.
We're glad to hear that. But I also think that as a part of your overall for that the person that is trained in radiology does an audit of those, yeah. And I was just hoping that.
Yeah, radiology is part of those multidisciplinary teams. Sir.
Correct.
How they're going to get to see the fluid.
Physician contracting service. This is, Dr. Kalapudi has done a lot of work on this, and this is a very high-level summary of all of those efforts in terms of the contracting services. The services are listed, and all of the services actually currently meeting their targets, and some of the current metrics needs optimization and strategic alignment, and we are working on those. As each of these contracts are coming up for renewal, there's a lot of conversation in what are your quality metrics, how is it aligned to the organizational goal, how is it aligned to the AIP, how is it aligned to the organizational priorities, and as this contract are transitioning from a claim to JPS, we hope to continue optimizing and aligning these KPIs. And once this process is concluded, this is something that we will bring it back to the board for your oversight as well.
And Dr. Karlapudi, you're meeting how often with these services?
So right now, ma'am, some of these services like the hospitalists, anesthesia services, ED services, we meet every month. The services, urology, ophthalmology, it's every quarter. So based on the impact of the service on the organization, at minimum, we are meeting them every 3 to 4 months, but the higher impact services, we meet them every month.
Okay.
What about pathology?
Pathology, we were meeting them monthly, and then as Dr. Badamusi said, as their numbers got better, we have now moved them to quarterly.
Are they listed here to that point?
I didn't see it.
There may be one that's missing.
Yes, ma'am. Your pathology is missing, but we're doing, yes.
I think that's what she was asking.
They're on the list.
Yes.
Just not
Just
this
want to make
list.
sure they hadn't gotten off.
No, they are very much part of my
We're
review.
actually working on that now. Supply chain. And this really has become very important in terms of quality because they really, really impact quality. And this supply chain metric speaks to if we have an equipment, as an example, that has a recall, how do we handle that process? Usually, where does the information come into the organization? Who needs to know that information? And how do we disseminate it? And we really feel that this needs to be a multidisciplinary effort. And this is still a work in progress. We have pulled together. We do have an emergence process in place that we're using now if we get any recall. But in future state, which will be soon, we've had a lot of meetings. This will be a collaboration between quality, supply chain, as well as medical staff. Some of this recall do require somebody to sign off on them, either a physician to provide appropriate notification to all of the organization, especially for this critical equipment, if there is a recall. So, but in currently, we are doing well, but not really hitting where we need to hit exactly with those resolved alert in a timely fashion, but there is a lot of work that is ongoing between quality division and supply chain to ensure we've mapped out the whole process, and we need to educate staff as well, because occasionally, especially for some of our subspecialty physicians or providers, they receive it directly from the vendor because they are very familiar with them. How do we get that and make it system-wide and provide notification to everybody that will even remotely come across that? And to not only that, identify all patients, because a lot of our patients these days have devices that could be recalled that they may not be aware of that is recalled. So we are creating a process whereby we provide patient notification in addition to any potential notification they must have gotten from the manufacturer, since they keep a record as well. So this is something that I'm really excited about. We've made a lot of progress with this, and we definitely will have a very good process in place shortly.
He said he's real excited about recalls.
I mean, CPAP recall is like a real thing right now. And so I can only imagine what it's like to be a pulmonologist. But yeah, it's like they're all out there.
Correct.
And you let your patient know you have one.
We're glad to have you, Dr.
Yeah, thank you.
Critical Care Committee. I will preface this presentation by saying critical care unit consists of 4 units at JPS. The ICU, which is P3, E3, P4, and P5. And combined, this is their data that was presented. And you can see the first measure there is hand hygiene compliance. We're currently at 94%. A little bit of comment about that. Based on national standards, for any unit, for one to be able to include them in analysis, you have to collect at least 200 data points for that unit to attribute it and to make any meaningful conclusion from it. Some of these units in their reporting period have not hit 200, so they have been excluded from the calculation until they get, because we do not want to skew the number either way. But currently our achievement is 94%, but we still believe that we need to increase this to 100%. Part of the difficulty is, even though we collect hand hygiene compliance by unit, providers go around the hospital all the time. A consultant may go into E3, they did not wash their hand, we don't know who that is. Even if a secret shopper were present at that time, they can only note it down. But to provide targeted feedback, I have engaged all of the executives, including all of the chairs. We are using an app to monitor hand hygiene. If you just round, you see anybody in the unit, even seeing a chair or the CMO going around the unit, pulling up the app and really auditing hand hygiene, I think sends the signal that this is important. And I've gotten commitment from all of the executives that if there is any feedback or pushback by anyone that is reminded of hand hygiene, that they really want to know about it. And I think that really is making an impact. But taking this to the next level will really require which is now the evolving standard, is electronic hand hygiene. It uses near-field technology with our badge as you're going into the room, whether you perform hand hygiene, and it displays it on the dashboard, and we can now provide a targeted feedback to each individual. Or you entered room P421, you did not do hand hygiene at 2:25 p.m. I think...
No, I had never heard of it. Long ago are the days I just walk in with my hands in my pockets and not touch anything and walk out.
So there's a lot of education, both at the...
I'm going to get counted. This is in residency. This is years ago. I'm not touching anything.
Yes, ma'am. So both at the MEC level, we have shared data, institution-wide data. The IP team actually did something interesting. They went about the hospital swabbing the handheld phone everywhere to show the pattern of microorganism that is growing. And we shared that with all of the staff to know that hand hygiene is important, not just for our patient, but for ourselves as well as we go from room to room. The other metric that the Critical Care Committee has been following is Tchd CLABSI. If you combine both, we're actually doing very well, and I'll be sharing detailed data about that shortly. Pain reassessment and pressure injury is another one. For the pressure injury, we're using improvement over self from 2023. Every single pressure injury and fall is analyzed in the unit, and specific targeted action plan developed for each individual case of fall or pressure injury when it develops. We also look at cumulatively what is the pattern of fall, zoom out, get all of the data over 6 months, over 1 year, 2 years, what's the big picture of fall, and we create targeted action plan for that. And so is our restraint documentation. MUSE is Modified Early Warning System. This is a computer-based algorithm, kind of like an AI that uses a combination of vital signs and trained in the patient vital signs to alert the frontline staff that this patient is getting worse and will require acknowledgement and resolution, either involving the MET team, which is our rapid response team, to come by and provide additional evaluation on the patient and create some action plan. And we're doing well with that as well. Next is a summary of our hospital-acquired infection. We have shared our Tchd and CLABSI data with you through the years, and this gives a year worth of data regarding our Tchd and CLABSI. Between 2023 and FY24, we have noted 45% fewer infection, fewer Tchds, as well as CLABSI. We have noted some significant improvement in our CLABSI elsewhere based on all of the intervention that we have been bringing and discussing with you. Surgical site infection, abdominal hysterectomy, 50%. The number is low to start with, but we still, again, the goal is and the aim is 0, but we are still bringing those down. SSI, after an initial success, we did have some months that we saw some bump, and we reiterated our intervention, and our plan now is actually, we're in the process of hardwiring all of those interventions into place. While we noticed a 43.5% improvement in our SSI, we still did not reach our target of SIR of 1, which is the number that is predicted for an organization our size, but we have come down significantly from around 2.3 to around 1.5 now that we are, and we'll continue to work on it. Hospital onset C. diff, this is an area of opportunity. We have consistently remained below national benchmark, only having about 20% of what is predicted for our organization. We noticed a bump earlier on this year, and we did a lot of investigation and intervention with this. We analyzed our pattern of antimicrobial usage as well as our hand washing data specific to the unit, shared that data with the medical staff. Additionally, we developed a drill down tool. Every single episode of C. diff is investigated, both by EVS, the physician, the nurses, and infection control. And we have a single sheet that we analyze each cases and we figure out why it happened and what the intervention intervention is. Through that intervention, you can see through Q3, we've actually started coming back down in the right direction. We are still way below the national benchmark for what is expected for organization of our size, but we continue to aggressively pursue all of our action plan related to hospital onset C. diff to make sure, again, that we eliminate this.
Did you say happening in Q2 that contributed to the increase? Was there anything you could?
It's between our antimicrobial data and our hand wash data.
Okay.
Generally, we noticed a slight, not statistically significant, but we noticed a trend towards decreased hand wash compliance, and which kind of like led to another vigorous campaign, especially in the unit concerned that we really need to get this back up. And as hand washing starts recovering,
You see this?
the C. diff
improve.
starts
Wow.
coming down.
Wow.
Yeah.
Real.
I thought it was not just, the alcohol sanitizer, but actual hand washing.
Actual hand
Actual
washing,
hand,
yes.
Right.
So is there a campaign to have actual hand washing, or is it just still?
Hand washing with C. diff. And that is really, in addition to standard precaution, you leave in the room, you have to wash it because, again, as you know, Dr. Allen, is a spore-producing organism, and the alcohol gel will not kill the
Doesn't
spore.
kill
We
them,
actually
yeah.
have to wash
And
it.
then the wipe down services with the
Yes,
different
ma'am,
wipes, yeah.
correct, which is why we involved EVS in our improvement process, because they have to actually terminally clean the room once a patient with C. diff has been discharged home or if they change rooms.
So I guess, okay, so that makes sense. If the patient is identified as being C. diff positive, then you initiate the hand washing protocol.
Yes, exactly. Once the C. diff test is actually ordered, then we place them under C. diff precaution.
I guess it's like capturing those who are positive that you don't know yet, right?
Yeah, exactly.
Nursing homes, things of that sort, probably, yeah.
Hard.
So this summarizes some of our action plans, and this also, you will see they're mentioned in the third row, PSI 4. Part of the IPPS by CMS has actually taken away or modified that metric into failure to rescue, and they backdated it to 2023. We are currently reworking and building the process of recalculating that, and we'll definitely bring it back to the board. We didn't want to present an outdated metric from the perspective of CMS. But we continue to do well.
Excellent.
We did discuss CMS star rating, and we have brought this program before you before as one of our external quality programs, looking at how does CMS calculate star rating. Some of this we know, some of the methodology we don't know because CMS does not disclose. These are the various domains that CMS uses to really score organization regarding their star rating. There is a data lag. There's a 1.5 to 2.5 years lag in CMS data. And for each of the domain, one could have a lag of 1.5 years, the other could have another could have a lag of 2 years, another could have a lag of 2.5 years, and they never disclose what the rationale is. But that's what they do, and they assign 1 to 5 stars based on an algorithm that they don't disclose publicly. They only mention the statistical model, but the algorithm itself they don't disclose. But the final scoring, when they put all of it together, ranges from minus 1.919, which is 1 star, to 1.330, which is 5 star. So the way you know you are going in the right direction with this measure is once you turn positive. If you go from negative to positive, you know you are definitely turning in the right direction, that some of the intervention are working. As a comparison, if you look at 2023, we were 3 out of 5 stars. We were negative 0.29. That's our cumulative score. But now we have turned positive in 2024, with some of our data now capturing into those adjustments at 0.02. We continue to work at this, and we really do hope that all of the work that we've been doing will start reflecting in short order in the CMS overall star rating for the hospital. Thank you.
Great report.
Yeah, I know.
Yeah,
Excellent.
great report.
Yeah, Dr.
Thank you.
Badamus has been a great addition to the quality team.
Thank you.
All right, we're losing our quorum. Thank you.
Thank you, Dorothy.
So I think with that, we are going to close the open session. Is that correct? Do I have to have a motion? No. Okay, so we will close. So we will go ahead and close this quality meeting, and when's our next one? In 3 months?
February.
February.
Okay. So, all right, thank you, everyone, for joining
Thank you.
today.